right, and we are live. This is my first time doing this, so I'm just going to do a few tests first. All right, testing. Microphone test. All right, welcome everyone to our knee pain seminar. My name is Curtis Pachoka. I'm a physical therapist here at Premier Physical Therapy. My background is I graduated from UNF, the Doctorate of Physical Therapy program, in 2015, and I've been practicing in orthopedics for about 5 years. So this knee pain seminar uh, doesn't necessarily have to be for patients with knee pain, but odds are you've probably had knee pain in the past, and odds are you're probably going to have knee pain at some point of your life. And even if you're the rare type of person who never gets knee pain in their lives, this can still be beneficial because some of the topics we talk about can help other sorts of pain that you have, whether it's in the ankle or the hip and so forth. So a little bit about our clinic, Premier Physical Therapy. We're a local PT-owned clinic. We're basically in the business of private practice, almost like a little mom and pop shop versus a big company. The benefit of that is you get more one-on-one care, more hands-on therapy, more attention, which usually results in better results. We have two locations, one being Jack's Beach, near Beach Boulevard and Hodges. And then Ponte Vedra, we have another clinic just past Palm Valley. Some of our subspecialties include lots of orthopedic patients, TMJ, which is jaw pain and facial pain, lymphedema specialist, and a lot of focus on running and golf programs. So just starting things off with some basic anatomy, you have four main bones in your knee. The biggest bone is the femur, It is basically your thigh bone. It's the biggest bone in the human body. Then lying on top of the end of your femur is your patella, or also called your kneecap. And basically, it sits in a groove located in your femur. And so this groove acts like a train track, and it keeps your patella or your kneecap on track while the knee is moving. Your tibia is basically your shin bone. It's the weight bearing bone of your leg. And then the fibula is the smaller bone next to your tibia. Doesn't really bear much weight, but it's a joint and the muscles attached to it, so it's still pretty important also. The main muscles around your knee, quadriceps muscle, consists of 4 muscles, one going all the way up to the hip, the others attaching mainly on the front of your thigh. The hamstring muscles are on the back of your thigh, and you have 3 of those. They're basically the prime movers. Then you also have some groin muscles that attach to the inside of your thigh. You have an IT band that touches on the outside of your thigh. And then you have some leg muscles that attach to your knee, being your calf muscle and your shin muscles. Ligaments, everyone's heard of ACL. It's a very commonly known ligaments that a lot of sports players injure. And the acronym stands for anterior cruciate ligament because it forms an X to hold your knee together. Anterior is the one in the front. The PCL is the one in the back. You also have the collateral ligaments being the MCL and the LCL. Then we have cartilage, articular cartilage, and the menisci. So the articular cartilage is this shiny piece right here. It's very good for creating smooth movement in your knee. When you get older or when you have arthritis, that's from damaged cartilage. And the best thing I can compare it to is when I go fishing, I use a spinning reel. And when I first buy the reel, it's very smooth as I'm reeling in. But later on, if I drop it in mud or it gets older, it starts to catch, grinds, make sounds, just it's not as smooth anymore. And so what I have to do is take it apart and find the ball bearings. So what I can compare the cartilage to is mainly the ball bearings. They help my reel move smoother, especially if I put oil on it. And in the human body, we don't have oil we can put in your knee, but we have this synovial fluid that surrounds it kind of lies on top of your cartilage here, and it can make your knee move a little bit smoother. And then last, we have the meniscus or the menisci. They're mainly your shock absorbers. If you think about a car that has suspension, a lot of springs on the car, you can go off-road and it absorbs all the bumps and shocks a lot easier. So if you lose your meniscus, you can have a far less shock absorption as you're jumping or walking around on your knee. Common causes of knee pain: got arthritis, meniscus tears, ligaments, sprains, and tears. This is mainly age dependent. Most older people will probably experience more arthritis. Middle-aged to younger people could experience meniscal tears. And then very young athletes usually would experience ligament sprains and tears. So knee pain may also originate from disorders of the foot or ankle or the hip, which can commonly create increased stress at the knee. So the knee I usually refer to as almost the middle child as far as who gets picked on the most, the older child, the younger child, or the middle child. A most common answer I feel is the middle child gets picked on the most. So if your hip has some stiffness or weakness, or your ankle may pronate too much or it's stiff, your knee can get picked on because the knee can only bend and straighten, and it only has one plane of motion. And your ankle and your hip can really rotate in many different directions. So if something's wrong with the ankle or the hip, it's really gonna turn the knee probably into the wrong direction in order for it to be efficient. So we're gonna go over some injuries, including patellar tendinopathy, T-man syndrome, patella femoral pain syndrome, and pins and serine bursitis in the next couple slides. So first one, osteoarthritis, most common type of arthritis. Other types would include rheumatoid arthritis. That's something we don't usually see in physical therapy. You probably have to see a rheumatologist that can deal with all the bone erosion. Also, rheumatoid arthritis is an autoimmune disorder, so you probably need some kind of steroids to help prevent your body from fighting itself. But osteoarthritis, you can still have degrading of the cartilage. And in this picture here, you can see the smooth surface of the articular cartilage. And then here you have little spots where it's what we call bone on bone. If you get an x-ray, you'll see the space between your bones is decreased, and running out of space is typically the bone on bone, where the bone isn't like a ball bearing. It's not a smooth surface. When you're, for example, when I'm reeling in the fish, is very smooth. When you have bone on bone, it's going to be grinding and making sounds and catching, causing a lot of friction. And you can imagine if that was in your body, it's going to cause a lot of pain and discomfort. Solutions for this, of course, we can talk about later, but a lot of people do get a knee replacement. Well, they'll pretty much replace the surface with a prosthetic. That way you don't have any bone on bone anymore. The typical presentation is stiffness in the morning. Usually the first 30 minutes in the morning, your knee is very stiff, but as you move it and loosen it up, it tends to feel a lot better. You'll feel pain deep in the joint. It's not going to be superficial on the skin. It's going to be deep in that joint. Arthritis doesn't always equal pain. So what I want to go into further is something we'll probably be talking and discussing a little deeper in the future. But it's this symptomatic versus asymptomatic. This is mainly focusing on people who've gotten X-rays or MRIs. When you get an X-ray or MRI of the knee or the back or the shoulder, it's a little bit different than when you get these tests done on your organs. Usually, say I got a CT scan on my organs, they would say normal, normal, not normal, normal, normal. So you would know if there was a problem or not. When you get a knee X-ray or knee MRI, it will basically never say your knee is normal. You could be young, old, you can have pain, you cannot have pain. So there's a lot of studies. There's one study I can pull up for you guys by Yermazi in 2012, where he's a radiologist and he took MRIs on patients or people without knee pain and with knee pain that were 50 or above. And he wanted to compare the differences between the MRIs. And they were virtually the same. They all had 87% of the people without pain in these MRIs had some sort of abnormality in their MRI. So what that goes to tell you is you can't solely rely on your imaging. I have a lot of patients that say, don't I need imaging before I go to physical therapy? And the answer is no. We can do a very thorough physical examination that will end up being more useful than a lot of imaging that you get. All right, so the next thing we're going to discuss is meniscal tears. So in this picture here, you have a red zone and you have a white zone. So you can probably guess which one heals better. The red zone heals better. The red color means it gets more blood flow, and you can't heal without blood flow. So any injury where you don't have blood flow, you're probably not are not likely going to heal very well in that area. So then the solutions for that could be surgery, but also therapy can help, as I'll discuss later. So meniscus tears are typically painful when weight bearing. As I showed you earlier, they're the shock absorbers of your knee. So they act like a suspension system. Uh, so to put some stress on the suspension system, you need to put weight on it. So this injury, you'll typically stand out if you're putting weight on it and you're twisting it, you're putting weight on it and you're squatting or going downstairs. That will usually trigger the pain in a meniscus injury. But not all tears are painful. As I discussed earlier, you can have imaging that confirms you have a meniscus tear, but be asymptomatic, meaning you don't have any pain. There's another study I don't have the author of, but he did MRI on basketball players on their meniscuses, and 43 out of 44 of them had some kind of abnormality in their meniscus, but they didn't have any symptoms. So what that tells you is you wouldn't want to do a surgery on a meniscus tear you find in an MRI without first going to someone like a physical therapist or someone who can look at you physically to match up your physical presentation to the imaging itself. So it's that way to confirm that the surgery will work, that it's repairing something that's actually causing your pain. All right, next is ligament sprains, tears. Like I talked about earlier, this is usually in younger people who are playing sports, but it can also occur. Say you're stepping out of your car and you twist your knee. You could probably do it that way too. The key with ligament sprains and tears is your ACL, your PCL, even your MCL are very highly vascularized. So they have a lot of blood flow. So when you tear this tissue, it's going to swell up on you immediately and swell up on you in a large way. So that's how you would kind of confirm that's the injury you have if you had that presentation. Um, with ACLs, they typically involve hyperextending your knee so it bends backwards in the wrong direction. But for sports players, it also occurs when you plant your leg in the ground and you make a cut. And when you do that, the bottom of your leg, your tibia, and your foot are planted in the ground. But you're making the cut, so the bones go in the opposite direction, your top bone and your bottom bone, and it can twist that ACL and cause a tear that way too. Your collateral ligaments, your MCL and your LCL, are on the side of your knees. So they usually get hurt if something, a person, or some kind of object hits the outside of your knee or the inside of your knee. You can tear your LCL or your MCL. And what we'll discuss later is a position of your knee called genu valgum. It puts your knee in a position where you can be more prone to MCL injuries and delayed recovery. So with these ligament injuries, a hallmark sign of them is you feel unstable. The knee kind of gives out on you when you're walking, and you're probably going to need some kind of crutches or a cane to walk around to feel a little bit more comfortable, or some type of bracing to walk a little easier. All right. The next topic is Patella tendinopathy. So this could either be tendinitis, which is acute inflammation of this white tendon here, or tendinopathy, which is chronic, which is probably chronic is defined as over a length of time, over about 3 months. So if you had this pain below your kneecap for over 3 months, if it was tendonitis, it's probably now tendinopathy, which means the inflammation process is actually stopped. And what's going on now is the fibers that usually orient themselves up and down are all crossed up in weird patterns. And what we want to do there is in therapy, we want to jumpstart the inflammation process again just a little bit to realign those fibers. So we typically do a technique called deep fiber cross tissue massage or cross fiber massage. So this is typically found in the more active population, runners and jumpers. And the pain is usually at the bottom of the kneecap or the top of the tendon. And like we said, runners and jumpers, high impact activities could usually cause a lot of stress on these tendons. All right, IT band syndrome. The pain usually presents on the outside aspect of the knee. It is an overuse injury, so it's typically seen in runners. And it's typically due to muscle imbalances in the hip, training load errors. What that means is maybe you had some off time and you went right back into running or training without progressively building up to it. That's probably too much too soon, and it can lead to an overuse injury, causing the IT band syndrome. Also, if you have foot or ankle issues, as far as this picture here shows what we call the root of all evil, or I had a professor to call it that. It's genu-valgum of the knee, which is your knee is not in a proper alignment. It's a little more inward. And what that can do, it can put a lot of stress on the inside and the outside of the knee and actually stretch your IT band. So it's causing some friction on the outside of your knee. Also, having a lot of foot pronation can put your knee in this position. So in our clinic, if you have a foot that overpronates, or if it pronates too long during your walking, we can hook you up with a foot orthotic that will actually put your foot in a better position and basically correct this alignment just by putting a foot orthotic into your shoe. Patellofemoral pain syndrome. They call this a syndrome because it's really hard to diagnose what tissue is being injured. Your kneecap has a lot of things that attach to it. You have your quad muscles, you have hamstring muscles, you have all these muscles like calf muscles that surround your knee. Then you have these tissues, one of them being your patella retinaculum. It's a connective tissue that's not muscle. It's a passive structure that surrounds your knee. Some people have a knee plica, which is this tissue that some people are born with. And all these things can cause your kneecap to be painful. Also, you have cartilage underneath your knee, which can also be painful. So they call it a syndrome because we use certain categories to put you in order to find an effective treatment for you. So this one is also typically caused by overuse or patellar misalignments with this same position, the root of all evil. This is the genu-valgum position where your knee goes inward. Pain is located around the kneecap, but like I said, it's tricky to determine what tissue is actually injured because all the pain is located all over the kneecap. So we really have to put you in a category in order to find what a treatment is effective for you. Categories can include, you could be in the foot and ankle category where we put you in the foot orthotic to help your knee. You could have tightness in your hip, your hamstring, your IT bands, the hip flexors. So we can put you in the stretching of the hip category, or you can have weakness in the hip that causes your knee to go inward. And then we need to put you in the strengthening category. It could be you need all the above, all categories. But the pain usually increases with weight-bearing activities, but mainly bending activities of your knee in the downward motion, typically going downstairs and squatting, where you're putting a lot of bend at your knee, but also you're going down, either down the stairs or squatting. That puts a lot of compression on your kneecap, which would cause this femoral pain syndrome. Pens and serine bursitis, not the most common injury that I've seen here, but it definitely can happen, and we definitely keep our eye out for it if you're having pain on the inside of your knee. Basically, you have this little bursa, and what a bursa is, a fluid-filled sac to help friction as your tendons go over it. So you have three tendons that go over this bursa, the pens and serine bursa. Um, we call it Sergeant, a nickname to help us memorize what muscle tendons go over this bursa. So you got semitendinosus tendon, which is actually one of your hamstring tendons. Then you have the gracilis tendon, which is one of your groin muscles. And then you have a sartorius muscle attachment in the tendon there, which is actually the longest muscle of your body. So we have to check all three of those out and determine if they're tight, if they have any dysfunction as far as trigger points or muscle knots that could cause too much pressure on this bursa, cause it to get injured, inflamed, um, which would lead you to have pain. All right, so now we're going into the next topic is, say you have knee pain, what are you going to do? You have some decisions you need to make, and we're trying to make your decision making easier. We're trying to help people with problems, and we want to be the solution, or at least guide you to the proper solution. We want you to make a decision that you don't regret later, and we want you to make a decision that doesn't cause regret as far as probably financially. We want you to make the most cost-effective decision that benefits you the most. So these are typically the three decisions you can make. If you have knee pain, you can ignore it and hope it goes away. Sometimes that does work. If you typically have knee pain that just started maybe a week ago, maybe you just rest it, you ice it, and the pain goes away. And maybe it never comes back again. You can mask it where the pain doesn't go away, but you receive an injection or medications that make the pain go away and you feel better and you can do everything. But deep down, you're just covering it. You're kind of relying on these medications or injections to get you through every day. So eventually, that's probably going to catch up to you. It's probably not the best decision in the long run, but it can be a temporary decision that you make, or you can address it. There's many places you can go to. You can go to your primary care. You can go to an orthopedic surgeon. You can go to a chiropractor. You can go to the gym, a personal trainer. But we want to let you know physical therapy is also an option, and it's a very good option because you get a lot of things thrown into one. You get a person who can try to find the long-term solution to your injury. And like I talked about earlier, we don't rely on imaging like some other professions do. And imaging can be very misleading, like I talked about earlier. You could be you don't want to treat an x-ray, you don't want to treat an MRI. If you do that, you could be treating something that's really not causing you pain, or not, it could not even be a problem, because so many abnormal findings are found in patients without any pain. So it's hard to believe that these findings uh, could be causing your pain. If you have pain and you've got an MRI and X-ray, you want to double check that by going into somewhere that can physically assess you and to physically match up your physical presentation to what is likely the cause. And the X-ray and MRI can be assistance to that by helping us match up what your physical presentation was in the history portion of your physical exam to what is most likely matching with the results or the impression of the MRI that you received or the X-ray you received. So we feel like that could be the best route. Not ignoring it, not masking it, but addressing it, either with maybe talking to us. And I'm going to give you a couple of options for that in the future. Okay, so physical therapy, we believe, we could be a little biased for physical therapists, but we believe it's the best way to address the root of your pain because we've seen it. We've seen it. There's a lot of studies on it. We're not trying to BS you. We're not trying to be a gimmick, a quick gimmick to help you with your pain and to take your money. We're trying to get you long lasting results to get you back to what you enjoy. If you're having a problem, you're having knee pain and you're missing out on traveling, you're missing out with, spending time with your grandkids, you're missing out on your favorite activity, whether it's biking, running, sports. Uh, this is a very good solution to get you back doing it and create long lasting results. Because what therapy does differently, we not only look at your pain and try to get rid of it, but we try to problem solve why you had this pain in the first place. And that's what I feel a lot of places don't do. You have pain, um, you can get surgery for it, and they fix your pain. But why did you need surgery in the first place? Are you just more prone to this type? Are you more prone to arthritis? Are you more prone to meniscus tears? Or is it something that you could have been doing some little tip, either some exercise, some stretching? Is there something with your knee alignment that was a little bit off? Did you need a foot orthotic? Is there something that you're missing that put too much stress on your knee that caused this injury in the first place? That's what surgery won't address. They will fix your pain, but they will not address what caused your pain in the first place. And that could lead to, experiencing another problem down the line. If the original problem was never fixed, then getting surgery for it is just basically masking it until another problem develops from this in the future. Um, so that's our little spiel on that. We're not trying to be biased. We are physical therapists, but we want to get it out there what we do differently that sets us apart. So if you never had physical therapy before, you're probably wondering what it would be like. Not all clinics are the same. So I'll give you what our clinic is like, and you can compare it to another clinic you go to or what you've received in the past. But all our programs are custom, they're individualized to the patient. The first day we see you, we do a very thorough examination. We're looking at your posture, we're looking at your range of motion, we're feeling the muscles around your knee. We're feeling how your knee moves. We're making you do tests in person. We're seeing how you squat. We're seeing if you can stand on one leg and balance. We put all these findings together and we make a custom plan for you. And in this custom plan, we do a good amount of manual therapy. We do exercises. We do stretching. We also do a lot of education or consulting. So probably 5 to 10% is going to be consulting, education, us giving you advice on how to manage your pain and your injury. And then manual therapy. So every time you come in for your treatment sessions, we start off with the consultation, a couple of minutes. We then go into your manual therapy or stretching. We do a lot of different types of manual therapy. Our website can definitely share with you the different types. We do joint mobilization, soft tissue massage, we have cupping. In the future, we're probably going to have dry needling. Um, we have tools in our clinic, metal and plastic tools that assist with soft tissue massage. We use these with the intentions of fixing something we found in your first day examination, individualized for you to help you with your pain. And that's going to be probably, it could be anywhere between 25, 30%, even more, up to 50% of your care could be manual therapy. The rest of it is exercising and stretches that we're going to show you and progress you towards. And that's mainly the rest of the percentage, maybe 50% of your treatment will be stretching and exercise. We don't put you on a bicycle for 15 minutes. We don't put you in the, we don't just put you in a leg press for 15 minutes. We do a lot of hands-on. So you will get hands-on treatments, one-on-one treatments the whole time you're here. And the first 30 minutes is one-on-one, mostly manual therapy and consultation, which is very rare and can be very helpful. All right. So the overall goal is we don't keep you here forever unless you want to, have a maintenance program where you get therapy, every week for the long, and which can still be beneficial. But we know most people probably want to graduate from physical therapy and be 100%. So our ultimate goal is to get you independent and reaching your goals as quickly as possible. We're not going to sign you up on a plan for a year of therapy. We're trying to get you better in 4 weeks, 6 weeks, 8 weeks. We're trying to get you better pretty quickly. But of course, there are maintenance programs where some people can really benefit from a maintenance program where we work routinely on the manual therapy and exercises for a longer time than that if you choose to do so, if that's something you're interested in. So 3 options. You can come into the clinic for an evaluation, probably the best option. With the coronavirus going on, we realize that might not be an option for you if it's too vulnerable for you to come into the clinic. We are wearing face masks. We're all cleaning routinely, doorknobs, everything. So if you're comfortable with coming into a clinic where we're spacing everyone out 6 feet apart, we're wearing face masks, uh, this could be an option for you. You could schedule a telehealth evaluation or consultation. It's a little bit limited in what we can do. We can only basically talk to you and maybe look at your knee through the camera and guide you through some treatment. But we're not going to be able to do what we do best: our manual therapy and our just our constant assessment on the way you move. Um, not all insurances will pay for an evaluation of telehealth, so definitely call the clinic to kind of get a rundown of what your benefits include and what they don't include. Or option 3, you can kind of start your own exercise on your own through what you learned today. You could look up some exercises online. Um, you can try that route, and if it gets better, then that's fine. But if it doesn't get better, definitely what you can do is you can contact us. You can call us on this number below. You can call us and ask us questions. You don't have to just come in. You can use our time to just ask us questions to discuss your problem and discuss if you're or what direction you need to go towards, you can get our opinion, whether we think you would benefit from coming in for therapy, and we can give you a rundown on what your treatment might include. But definitely feel free to post any comments below. You can send any comments to this email, info@premierpptjax.com. What I'm going to do right now is kind of check the comment section for any questions that y'all might have. Info@premierpptjax. But if looks like there's no questions, but if you do have any questions, this webinar is going to be on our podcast, or sorry, it's going to go sent to YouTube. So it's going to be recorded, sent to YouTube. So you can watch it again. You can post comments on the YouTube channel in the comments section. We can answer your comments there. And that can be a very good resource for you to share with your friends. If you don't have knee pain, you could, use it as a resource if you get knee pain in the future. You can send it to a friend with knee pain, but also, a lot of these concepts can be applied to something that's not knee pain. But overall, in conclusion, physical therapy can be a good option if you have knee pain. If you don't have knee pain, if you fear that you might have knee pain in the future, go ahead, call us, email us with any questions. Other than that, thank you for joining us and spending your time with us, and have a good rest of your day.